Hello, I'm Ludvig Sollid working at the University of Oslo, and I've been asked to speak on the topic, will the treatment always be just a gluten-free diet? What's on the horizon? Will there be new drugs for celiac disease? And before I do that, I would like to declare my conflicts of interest. They are shown here on this slide. On my introductory slide, I had this painting by Van Gogh, Wheatfield Under Threatening Skies. Rather than showing this Van Gogh picture, perhaps I should use another one, this one, Starry Night, because that is what the horizon for drug development for celiac disease looks like. There are many stars on the horizon. Currently, there are nearly 30 drugs under development. And the drugs, as shown here on this slide, generously provided to me by Francesco Leon, shows drugs which are in clinical development shown in blue, and drugs which are in preclinical development shown in green. I will get back to details of this picture later. One reason why drug development for celiac disease has become such a fertile ground is that we now have detailed knowledge on many aspects of the pathogenesis. Research done over the past decades has uncovered many drug targets, and the drug development are being done at several frontiers. So genes are important in celiac disease. The concordance rate in monozygotic twins is 75%, 10% of first-degree relatives are affected. And the genes which are implicated have been studied by so-called genome-wide association studies, as in many other genetic diseases. In such studies, genetic markers across the genome are compared, the frequency of those are compared between patients and controls. And the results as shown here in the Manhattan plot is given as minus log 10 p-value. And this is a proxy for the effect size of the genes. And there are many genes that contribute to celiac disease susceptibility, but there is one region in particular which has a strong genetic signal, and that is HLA on chromosome 6. And the reason HLA genes are important in celiac disease is that there are HLA DQ molecules that present gluten peptides to T cells. The gluten peptides that these T cells recognize and which bind to the HLA DQ molecules are not exactly the same peptides as we eat. Following digestion, the gluten peptides are generated, and they are modified by an enzyme, transglutaminase 2, which converts certain glutamine residues to glutamate. And this process called deamidation leads to the formation of gluten peptides that binds very well to DQ2 and DQ8. And a T cell that recognizes the complex of a gluten peptide and HLA molecule become activated. And I often compare this T cell with the director of an immunological orchestra. And the activation initiates a cascade of events that eventually leads to the formation of the lesion with villus blunting and infiltration of leukocytes both in the epithelium and in the lamina propria. Previously, we thought that activation of these T cells was a sluggish process. It would take days. And we thought that none of the symptoms that the patients experience following exposure to gluten could be related to T cell activation. This we no longer believe in, as results from research done by Bob Anderson and others, partly in collaboration with us in Oslo, has demonstrated that these T cells can become activated very quickly. And we believe that the symptoms that patients get shortly after they have eaten gluten is related to the gluten, the activation of these CD4 T cells. And some of the results which have given rise to this understanding are shown here in this next slide, where patients in remission in Australia and Norway have been challenged with gluten. And blood have been drawn, and we have analyzed for cytokines in blood, in plasma, in serum or plasma, shortly after gluten exposure. And both patients in Australia had increase in cytokines, most notably IL-2. And this was not the case in patients who received a challenge with something that did not contain gluten. So clearly, this increase in cytokines is a gluten-dependent effect, and we strongly believe that the cytokines, at least IL-2, derives from the T cells. So we have studied gut T cells of celiac patients, and we have studied these T cells which are derived from gut biopsies, and what we can get then is tissue from the upper small bowel. And the T cells we are studied are effector memory T cells sitting in the lamina propria, the CD4 cells. And we also studied effector B cells, which are plasma cells that secrete immunoglobulin. The initiation of the immune response to gluten does not take place in these village structures. It takes place at specialized inductive sites, Peyer's patches and mesenteric lymph node, where antigen can stimulate T cells and B cells, and these cells interact and get activated. And once they get activated, they clone expand, and some of the cells also travel in blood and populate the effector sites. So if one wants to develop a drug that interfere with this activation of these gluten reactive T cells and the plasma cell specific for transglutaminase or gluten, it's unclear whether you need to target cells located both at the effector sites and at the inductive sites, and whether it be sufficient only to target the cells which are at the effector sites. That we don't know, and that is something we'll need to learn. Drug development is a tightly regulated process. One has to follow certain schemes to get a drug approved for use on patients. And I was attending a meeting at Columbia University a couple of weeks ago where Irina Levine from the FDA gave background on how to develop and get approved drugs in celiac disease. And what has become very important for assessment of drugs are patient-reported outcomes. And Irina Levin said that to develop a drug, it has to have clinical benefit. A key goal of any clinical development program is to demonstrate the clinical benefit of the therapy. Clinical benefit is a favorable effect on the meaningful aspects of how a patient feels, functions, or survives as a result of treatment. Clinical benefit needs to be clinically meaningful, measurable, and interpretable. And measuring clinical benefit in celiac disease, one has to assess the effect on both signs and symptoms and the underlying histological inflammation. One should determine appropriate instruments, tools to measure the relevant signs, symptoms that represent the clinical benefit in the target population. Submit data to support what degree of improvement in signs, symptoms provides convincing evidence that patients have benefited from treatment. And on this backdrop, patient-reported outcome has become important. And a patient-reported outcome is an assessment based on a report that comes directly from the patient without interpretation. It can be self-completed or interviewer-administered. The pro-assessment can measure patient symptom signs or an aspect of functioning related to disease. Only PRO assessment can measure symptoms a patient's experiences with the condition. And FDA has issued guidance for industry patient-reported outcome measures. And I think in celiac disease, there are two FDA-validated PROs currently, CED-PRO and CDS-D. These include a number of symptoms, not all the same. In CED-PRO, abdominal cramping, abdominal pain, bloating, constipation, diarrhea, flatulence, loose stool, nausea, vomiting, headache, tiredness are reported on, whereas in CDS-C, some of these are. I don't think that all these symptoms necessarily relate to gluten-induced immune activation in celiac disease patients. And the reason I say that is partly based on results reported by Davison et al. And work done by Bob Anderson and colleagues, where they did a masked one-off gluten challenge with vital gluten versus sham. And vital gluten is washed gluten where FODMAPs have been removed. And doing this one-off gluten challenge, they saw that of the CED-PRO scores, it was only nausea, tiredness, and headache that became significant. And on the symptoms of occurrence, it was only nausea that became significant, suggesting that some of these other symptoms are not related to activation of these CD4 T cells. What the symptoms are related to is currently unknown. Possibly it could be effects of FODMAPs. Speaking about gluten challenge and meaningful PROs. I think one also has to think about PROs, which you can see during short-term exposure to gluten. That means in hours and days. In contrast to those symptoms you can get on longer term, where you're exposed to gluten for weeks and months. And for instance, nausea, I think, is something that patients would experience on short-term exposure to gluten, whereas I don't think patients to the same extent would see that in long-term exposure. And I think, for instance, fatigue is something that is more prominent during long-term exposure than in a short-term exposure. So using these PROs, one has to think about the indication of the drug and whether the PRO measured during drug development are actually meaningful for the symptoms that the patient can get with the treatment that one is planning for. So PROs are important in drug development for celiac disease. And there is one imminent question that comes to me in this situation. In celiac disease, where we have this detailed mechanistic insight, and this is in contrast to many other immune diseases like type 1 diabetes and IBD, to mention a few, then it's a question whether drug development should be guided first and foremost by PROs. I can understand that in diseases where you don't have detailed knowledge of the pathogenesis, one has to use symptoms as the main guidance. But in this disease, where we have detailed knowledge and where the drug is going to interfere with a specific process, I would think that it would be meaningful to develop a drug to see that it's effective to interfere with this process. And then along with that, try to see whether it does something with the symptoms which is related to this disease process. And if this is to be done, I think we need good biological surrogate markers, and this is a challenge to us to develop those. And I think this question is something that we all should think about, including the regulatory authorities. So coming to the drugs, there have been developed drugs which are modified or pre-treated gluten. There have been developed drugs which should bind to gluten and sequester gluten from entering into the place where they can meet, with gluten can meet immune cells. It can be chemical compounds or it can be antibodies. And there has also been developed glutenases that will chop up gluten so that there are no peptides which are immunogenic, which can get in touch with immune cells. There are drugs which aims to interfere with the penetration of the gluten peptides across the epithelial barrier. There are drugs which are transglutaminase inhibitors. At some point, there were drug programs trying to develop DQ2 blocking or DQ agents that block binding of peptides to the DQ2 and DQ8 molecules. It was not very successful. I'm not sure how much these programs are pursued currently. There are a number of programs which either affect the trafficking of cells or the products of these lymphocytes, be that chemokines or cytokines. And finally, there are a number of drugs which are aiming at the gluten-reactive CD4 cells. It can be drugs that aims to tolerize these cells directly, or it can be drugs that aim to induce regulatory T cells, which would control the action of these gluten-reactive cells. And I will discuss with you two programs aiming at the CD4 cells. One program that was discontinued after an interim analysis, and this was a program by Immusanti. And I will discuss with you a program that was formerly done by Core, now taken over by Takeda on the drug called TAC101. And on speaking on TAC101, I will show you some slides I got from Kieran Kelly, which he presented at the Celiac conference at Chicago at the Columbia University. So this drug is nanoparticles which are filled with gliadin. They are given intravenously, they traffic, and they get to the spleen and processed by antigen-presenting cells. And after that, the idea is that they can induce tolerance to gluten. During his presentation, after his presentation, I asked Kieran Kelly whether the gluten in the particles or the gliadin in the particles is deamidated. And he said that they, in principle, it is not, but they have discovered that During the preparation of the particles, some of the gliadin gets deamidated, which could explain why it can activate or act on these CD4 T cells, which are recognizing deamidated epitopes. So Kieran Kelly presented a phase 2A trial on TAC101, which was done in study subjects who had well-controlled celiac disease. They were either enrolled to receive drug or placebo by infusion. They underwent the 14-day gluten challenge, and 6 days into the challenge, blood was drawn to look for gamma interferon ELISpot to detect gliadin reactive T cells. On day 14 in the gluten challenge, a biopsy was taken, which was then used to examine for pathology in the duodenum, villus-height crypt depth ratio, and the number of intraepithelial lymphocytes. In addition, safety assessments were done. So the primary endpoint of this trial was the number of gliadin reactive T cells as measured by gamma interferon ELISpot. And the trial met its primary objective. There was a reduction in gamma interferon spot forming units in response to gluten challenge. This shows the results of the placebo treatment. This shows the results of the drug. And there was a significant difference between the two groups. There was also a tendency that the pretreatment protected against histological damage during gluten challenge. This is the results of the placebo, and this is the results of the drug. There was a tendency, although it didn't quite reach significance. Adverse effects was examined. There was no serious adverse effects. Looking for other symptoms, there was no difference between drug or placebo. And some of the symptoms that were analyzed, like nausea, diarrhea, vomiting, they are also in the patient-reported outcomes for celiac disease. So if this trial had been judged by the ability to change PROs, I don't think it would have reached its endpoint. And I think that is food for thought. And I think it's also questions how useful are PROs to guide drug development in celiac disease. The other program I will discuss was the one of Immunosanti, which was stopped after its interim trial. The drug Nexvax2 is a combination of 3 peptides that contain 6 immunodominant epitopes that bind to HLA-DQ, which can stimulate these gluten-reactive T cells. And the idea behind the drug was that when given in the skin, it can induce tolerance from these specific T cells, but also in gluten-reactive T cells, which are recognizing different gluten epitopes. And Leslie Williams and Robert Anderson have generously provided me with these slides, which Robert Anderson presented at the Celiac conference in Paris last autumn. So this is the design of the study. There was a screening food challenge to identify subjects who would respond to gluten. The patients were given escalating doses or placebo, and they had a maintenance dose. And when they were on the maintenance dose, they were undergoing a food challenge, and symptoms were recorded, and also IL-2 measured in blood was done. This trial did not reach its primary endpoint. There was no difference in symptoms between placebo-treated or Nexvax-treated patients. And there was no difference in the levels of IL-2 in blood taken for after the gluten exposure. So this trial was therefore discontinued. This trial used this surrogate marker IL-2, and as you can see, there is this rise in IL-2 on gluten challenge, but there is a huge inter-individual variation. And that's this, when you do a group comparison, you need the certain sizes of your groups to get significance. And this issue of big individual variation is also the case for gluten tetramer positive cells, here given as gluten tetramer positive cells, integrin beta positive cells with an effector T memory phenotype. Huge individual variation. And again, this has impact on the group sizes when you do a group comparison. So we have been seeking to try to find a marker which is more homogeneous among the patients. And we would like to suggest that the expression of CD38 in these tetramer positive cells expressing beta 7 could be one. You see on gluten challenge, there is a uniform increase in expression of CD38. And in a later study, we did a kinetics, and we observed that in some of the patients, there seemed to be protracted kinetics, suggesting that maybe day 8 is a better day to examine for CD30 expression than day 6. So we would suggest that this could be a surrogate marker to be included in future studies. So coming back to the Starry Night picture by Francisco Leon, many drugs, I hope, but also believe that some of these drugs will become an alternative for celiac patients to the gluten-free diet. It may take some years, but I have a strong belief that it will happen. So we just have to cross fingers and hope for the best. Thank you for the attention.